recording.
Okay, the recording is started. I'm going to start the broadcast now.
The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everyone, to our second Cure-OM webinar. This webinar is on systemic therapies for ocular melanoma. We're glad that you could all join us today. I know some of you are in different time zones, so thank you for bearing with us in the timing of this. I'm Sara Selig, the director of Cure-OM, and just wanted to introduce with a couple things. One, I wanted to make an exciting announcement that we have for Cure-OM, which is that we have a new team member. We have just hired Molly Stofa, who is a nurse, as our Cure-OM program coordinator. So keep your eyes out on our Facebook page and on our website for more information. We're very excited to welcome Molly as part of our Cure-OM team. So welcome to Molly, and we look forward to working with the community moving forward. Our webinar series is part of our overall Cure-OM educational agenda, and we try to have at least a quarterly event. So our next event that I wanted to make sure you all know about, and Scott, can you move the slides forward?
Sure.
Great, thanks. I just wanted to make sure that all of you know our next event after today's webinar is our in-person Eyes on a Cure Patient and Caregiver Symposium. It will be held in Houston at MD Anderson Cancer Center March 2nd and 3rd. Registration is online and open on our website, so we look forward to seeing you then. And in the meantime, Scott, can you move the next slide? So while the slide is moving, here we go. I just wanted to let you all know how to keep in touch with us in the meantime. So we have the Cure-OM website, our electronic newsletters, which you can also reach online and through social media, through Facebook and Twitter. We try and keep the community updated on new scientific advances as well as information about Cure-OM. And then we have an online patient forum where people can go and discuss things as well. So that is the update from Cure-OM. Scott, can you go to the next slide? And I want to briefly introduce our panelists today. We are very lucky to have Dr. Jeffery Weber from Moffitt Cancer Center speaking to us today about immunotherapies for ocular melanoma, and Dr. Keith Flaherty from Massachusetts General Hospital speaking to us about targeted therapy for ocular melanoma. So thank you both for being with us today, and I will hand it over to Dr. Weber.
So let's go to the next slide, if you'll have my slides up there.
And while we're waiting for Dr. Weber's slides to come up, let me just mention that we will have time for questions and answers at the end of this as well.
So good evening, or if you're in the Pacific Coast, good afternoon. I'm Jeff Weber. I'm a medical oncologist from the Moffitt Cancer Center in Tampa, Florida. And I've had a lifelong interest in the immunotherapy of melanoma, and I guess I can lay claim to never having excluded patients with ocular melanoma from any of my own immunotherapy trials, because in my view, immunotherapy should be as relevant to ocular melanoma as it should be to any type of melanoma. That being said, there's some unusual twists to ocular melanoma in that there's controversy over whether the infiltration of immune cells into the ocular melanoma is a good thing or a bad thing. In traditional cutaneous or skin melanoma, or melanoma of skin origin, having a lymphocytic infiltrate is a good thing, and you can even expand those cells and grow them from the metastatic lesions and use them to treat patients. With ocular melanoma, it's not quite as clear, and my suspicion is many of those cells are actually, well, the bad guys. They're so-called suppressor T cells and myeloid-derived suppressor cells. And that's why, as you'll hear in a few minutes, some of the new drugs that work in cutaneous melanoma may also have some promise in ocular melanoma. So let's go to the next slide. And I guess we just need a little bit of background. Keep in mind, since I'm going first, I'll give you the basic stuff. Of patients who have ocular melanoma, a significant proportion will eventually spread, and as many of you know, very often it goes to the liver in something like 70% of the patients. But still, that's a very high proportion. 35 to 50% of patients will progress and metastasize and spread, and it can take place over a long period of time. It can happen 10 or more years out. And what is associated with that outcome is the thicker the tumor, the depth, whether it spreads outside the white of the eye, whether it has this different appearance, we call it epithelioid or mixed as opposed to spindled. If you have lots of what we call mitotic figures, that means the cells are dividing rapidly. That's usually bad news. And this unusual scenario where these TILs, which means tumor-infiltrating lymphocytes, if you have lots of them, it's not always a good thing, as opposed to skin melanoma, where having lots of them is usually a good thing. And as Keith will tell you, there are two classes of tumors that are distinguished by their expression of a bunch of genes, and I list up here the names of the genes. I don't think it's really important. Suffice it to say that if you lose expression of some genes from chromosome 3 and gain expression of genes that are on a different chromosome 8, that's usually associated with a poor outcome, and you can actually determine, if you look at the genes that go up and down, you can calculate a formula, and you can calculate patients who will do very well and never relapse and distinguish them from patients who are going to do very poorly. And Keith will tell you later about this BRCA1 associated protein, otherwise known as BAP. And it appears to be mutated in lots of patients and may be a target for the kind of targeted therapy he'll talk about. Or it could even be a target for a vaccination strategy, since it's generally mutated in lots of patients with ocular melanoma. And guess what? It's on the famous chromosome 3, which is often broken or abnormal in patients with ocular melanoma. Let's go to the next slide. And we're going to talk about immunotherapy. And immunologic therapy for cancer comes in a whole bunch of different forms. Basically, it is encompassed by 9 different treatments. And high-dose IL-2 is a cytokine, a substance made by immune cells, and that was approved way back 14 years ago for metastatic melanoma, but to be honest, it has very little activity in ocular melanoma. Same thing for biochemotherapy, where you combine a lower dose of that same substance with 3 chemo drugs and alpha interferon. We kind of call that the kitchen sink regimen. It's literally you throw every drug with some activity at melanoma, and again, there's not a lot of evidence that either biochemotherapy or interferon alpha has much of an impact on ocular melanoma. There are people who do vaccine strategies, and they'll make little fragments of proteins, which are called peptides, or they'll take whole proteins of substances that are on the ocular melanoma and use those to vaccinate patients. And vaccines alone, to me, are unlikely to help either cutaneous melanoma or ocular melanoma. Dendritic cells are cells in your body that show antigens to the immune system. They're immune-stimulating cells. And you can add substances to the surface of that so-called dendritic cell. And there's a little bit of promise there, but again, it's not easy because you have to prepare the cells from the patients, inject them under the skin or in the lymph nodes, and it's not a very practical way to immunize someone. Adoptive cell therapy is a scenario where you actually take immune cells out of the tumor or out of the blood and you expand them outside the body. And that has shown some significant success in patients with traditional cutaneous melanoma. And there are anecdotal reports that you can have significant tumor shrinkage in patients that have ocular melanoma when you treat them with this cell therapy. But it's expensive, it's complicated, it's difficult, and not a lot of companies are willing to invest in it because it's not a drug that you pull off the shelf. It's the ultimate individualized or personalized care. Cytokines are substances like that IL-2. Single cytokines are probably not going to be real useful, although they would have some activity at promoting the ability of other treatments to work. At the bottom, that immunoembolization is a scenario where if you have liver-only disease, which is common, as you all know, in ocular melanoma, you can inject immune substances directly into the liver, just as you do the so-called chemoembolization. And there's a little bit of promise there, but again, ultimately, most patients with ocular melanoma will either resist the local treatment in the liver or they'll disseminate outside the liver, and you can't just treat the liver. Finally, two of the most promising drugs we have for melanoma are the so-called checkpoint protein inhibitors, which are antibodies that release the brake on the immune system. And that's probably pretty important for ocular melanoma because all those immune cells found in the ocular melanoma tumors are probably the bad guys. And they express lots of material that I would consider to be the brake on the immune system. So if you can cut the brake, you might be able to benefit people with melanoma, and that certainly is true for the one drug that's already been approved by the FDA. That's called ipilimumab. And if you go to the next slide, and there you go. You see a nice cartoon, a colorful picture, which on the left shows an immune cell, a T cell, capable of killing a tumor, stimulated by something called an APC, which is an antigen-presenting cell. And if you have the proper recognition of the antigen, which is the substance, that little red dot, that's presented to the immune cell for its recognition, it binds to what we call the TCR, the T cell receptor. And that's kind of a weak bond, so you need these other substances that stick those two cells together to stimulate the immune cell. That's called CD28 and B7. And when that happens, you boost the T cell gets all revved up, and it can destroy the tumor. However, that interaction contains within itself the ability to be braked or downregulated. So for every accelerator in the immune system, there's a brake, which kind of makes sense because you're going to need some way to shut off the immune reaction once it starts, or else we'll all die of autoimmunity. So what happens is that little orange thing, that CTLA-4, that's the brake. Now the brake's not always on, but if the brake is sequestered or kept in the cell, it gets exported to the surface, which you see in the middle picture, and it blocks the binding of these substances that activate the T cell, and the T cell doesn't work anymore. The problem with cancer is there's too much brake. It's like trying to drive your car with the parking brake on. Well, that works, but the car doesn't drive really well. Adding the ipilimumab, which is an antibody, as you can see in the cartoon, that blocks the CTLA-4, it's kind of like you releasing the parking brake, and now your car can drive. Except it's like releasing the parking brake and the regular brake and cutting the cables. The car drives great, but stopping it can be a little bit of a problem. At any rate, that drug was tested in traditional cutaneous melanoma, and it was approved by the FDA in 2011 because it clearly prolonged survival in randomized trials, either as the first treatment, where it was given with chemotherapy versus chemo alone, or it was given as the second-line treatment or even third-line treatment compared alone to a vaccine, which really didn't work particularly well. So if we look at the next slide, it tells us that there have been large studies done, and as many of you all know, ocular melanoma is a rare disease. There are only about 600 cases a year that actually ever spread and would be treated by the medical oncologists like me or like Dr. Flaherty. But one of the largest groups of ocular melanoma patients ever treated was collected in what's called a compassionate use trial of thousands of patients. And in the United States, ipilimumab, this anti-CTLA-4 antibody, which has about a 10-15% response rate and prolongs survival in cutaneous melanoma, was also tested in different kinds of melanoma. And there were over 100 melanoma patients who had ocular melanoma treated on this so-called compassionate use trial. That's a trial that you do when you're pretty sure the drug is going to get approved by the FDA. You know that it works, and while the FDA is mulling it over, the FDA gives you permission to treat patients in a way that's almost like standard office practice. And it's called a compassionate use trial. And several thousand patients were treated on this trial, and there were over 100 ocular melanoma patients. And interestingly, the survival at 1 year and 2 years was no different than all of the cutaneous melanoma patients treated, suggesting that its activity in ocular melanoma was no better or worse than standard cutaneous melanoma, where we know it has a 10-15% response rate. In that trial, they did not calculate response rates because it's not a typical trial where you collect CAT scans every 12 weeks or every 8 weeks. That wasn't a requirement. So the best you can do is to look at the endpoint that you know is real, which is, are the patients alive or are they dead? It's hard to mess that one up. So they looked at survival, and the survival of the ocular patients was just as good as the survival of the patients who had standard either cutaneous or mucosal melanoma. Now, the Italians have looked at this also, and they did a smaller trial, much smaller, and they found that they had a 5% response rate. There was a rate of disease control of about 35%, which means stable or shrunk. Survival wasn't great, but these were very, very sick patients who had no other options. So the bottom line is the toxicity for the ocular patients, which is all immunologic related, was similar to any patient who had ever been treated with this drug. And the survival at 1 year, and it turned out 2 years and 3 years, was very similar, suggesting that there's no good reason to discriminate against an ocular melanoma patient when it comes to the use of this new drug ipilimumab. And in fact, the FDA approved it for metastatic melanoma. They didn't say metastatic cutaneous. It was any metastatic melanoma. So bottom line is, I think it's a drug that has some promise, and patients with ocular melanoma, in my view, should not be excluded from new combination studies of this immune stimulant ipilimumab. So let's skip a couple of slides. And skip that slide because it just gives you more of the same. So let's stay there. And right there is another cartoon which describes yet another antibody. And you'll notice the cartoon is a little bit similar. Over on the left, you have an immune cell. We call that a naive cell, which means it's not an educated immune cell. And it can recognize that antigen. That's the little red thing. And that's the thing it recognizes on either the tumor cell or the APC, the antigen-presenting cell. And as I told you, you get a positive signal when you get two different bonds. The antigen is recognized by the T cell receptor, TCR. Then you get this CD28B7 interaction, which strengthens the bond and gives the cell a signal to get revved up. Well, that's okay, and that gives you an activated T cell. But the problem is the T cell turns on the brake. And the brake, in this case, is a different brake. It's called PD-1. And when the PD-1 meets up with its counterpart, which is called PD-L1, it gives the cell a signal to, well, we call it exhaustion. It essentially causes the immune cell to show an exhausted state, and it no longer functions. And those exhausted cells are useless cells. I mean, they no longer are able to do the things that an immune cell does. They can't destroy the tumor. They can't make cytokines. They can't do anything. They're useless T cells. But if you block the PD-1, PD-L1 interaction with another antibody, and that's a PD-1 antibody, it has a name, it's called BMS 936558, you rescue the T cell, and that's the term. The T cell is no longer exhausted. It's like taking a runner who's completely exhausted and wiped out and feels like a wet noodle at the end of a long race and giving him an injection and rejuvenating him. And all of a sudden, the T cell works again. And guess what? In cancer, particularly in melanoma, most of the T cells that could kill the tumor are exhausted. Not only do they have lots of CTLA-4, they have lots of PD-1. So if you could block either of those breaks or those signals, the T cell might work better. And in fact, if we go to the next slide, there's not a lot of data available. But it's all anecdotal. But it turns out that you can see patients that either have long-term stability or responses who have ocular melanoma treated with these. I actually show my own personal data, and I performed a trial of 34 patients who had metastatic melanoma who got different doses of a certain PD-1 antibody from Bristol Myers Squibb, the one I just mentioned. Of those 6 patients in the initial trial, in patients who had never seen ipilimumab, 1 patient was stable and 5 progressed, and the stable patient was stable over a long period of time, more than a year. However, if we look at our subsequent patients, we have seen a responder or two amongst the handful of patients that had ocular melanoma if you take that antibody and treat patients who already had or failed ipilimumab, the CTLA-4 antibody. And if you talk to the different companies, of which there are 5 different antibodies against PD-1 or PD-L1, all of them will give you a wink and a nod and say they've seen activity in ocular melanoma. But since none of this is published, nobody's willing to go on the record, but I happen to know virtually all of them. And all of the representatives or principal investigators of these trials will admit to you with a wink that they've seen some activity in ocular melanoma. And it kind of makes sense because the immune cells that infiltrate the ocular melanoma are essentially useless T cells. They appear not to function very well. And when you try to expand them, as we have in our experience at Moffitt, they don't expand very well. But if you block the brake, I bet they would expand. So let's just quickly go to the next slide. It's not that, it's next one. And go to the next one. It talks about TILs. And as I told you, TILs are so-called tumor-infiltrating lymphocytes. And you can take a metastatic tumor that you remove from a patient, and you can cut them up. And you can then chop them up into little bits and pieces, and you can actually grow the cells from within those tumors. And if you do that, it's not always easy to grow the lymphocytes from the ocular melanomas. You can grow them from 80% of cutaneous tumors, but in the small number of patients tried, only about 1 out of 4 of the tumors were able to grow lymphocytes. And of those 4 patients, you chop up the tumors into little bits, and you take each little bit and you put it in a well of a plate. So each tumor could have 50 little individual cultures of immune cells. So that figure of 28.5% reflects the total cultures that grew out of those 4 tumors. That's a very low number. It's usually much higher. So it says there's something bad about those T cells that infiltrate the ocular melanomas. But if you manipulate the cells outside the patient, you can actually, outside the body, you can actually get the cells to grow better. That being said, we're one of the few groups that's actually tried to grow the cells for therapeutic purposes. And we've done this in 1 patient with ocular melanoma, and we simply couldn't get the cells to grow because the tumor in the ocular patients is filled with suppressive substances. So one of the things you can use to try to grow the cells better is PD-1. And it turns out that in the 1 other patient we tried, if you add the PD-1 antibody to block the brake to the cells, it allows them to grow better. So the idea would be if you could treat patients with TIL, you'd also treat them outside the body, and you'd treat the patient with the PD-1 antibody to overcome the limitations of the really, I would call, unfavorable immune microenvironment in the tumor. So let's go to the next slide. And again, immunotherapy with these checkpoint proteins like ipilimumab or PD-1 antibody, and by the way, there are new ones coming along, it works as well as systemic therapy, immunotherapy, in traditional cutaneous melanoma. Now, the jury is still out because, as I told you, all that anyone's willing to tell you is anecdotal reports with a wink and a nod. But the PD-1 and the PD-L1 antibodies both have some promise in ocular melanoma, and I think that agenda needs to be pushed. I'm the only one who's actually treating ocular patients with PD-1, and that trial is almost done. But I think it certainly merits a repeat trial just in the ocular melanoma population. And I think that adoptive cell therapy with something like PD-1, where you actually remove the T cells from the tumor, which we know are not very good cells, but expand them in the presence of substances that can reactivate them, like PD-1 antibody, I think has a lot of promise. So that's where immunologic therapy is headed. We have new checkpoint protein inhibitors like LAG3 and TIM3 that'll come up in the next few years. I would be willing to bet they will be useful in ocular melanoma. So I think we need to give way to Keith, who's going to give you a totally different viewpoint, but he's going to talk about targeted therapy for ocular melanoma.
Thank you very much, Dr. Weber. And now we'll hand it over to Dr. Keith Flaherty, as Dr. Weber mentioned, to talk about targeted therapies.
Thanks, Sarah. Thank you, Jeff, for such a beautiful introduction to the topic of immune therapy. I want to be totally clear that over the course of my comments, as I'm going to dive in on the topic of a real explosion in terms of our molecular understanding of uveal melanoma, in terms of the types of genetic alterations that happen in these cells that we think are now pointing us towards new strategies for really targeting those abnormalities themselves or the immediate consequences of them, that it is also quite possible in the years to come that there will be an intersection between this concept of targeted therapy with immune therapy. In other words, that it may well turn out that the optimal treatment strategies turn out to be combination strategies that really weave together these two different types of approaches. We have a lot of reason to believe right now in cutaneous melanoma, in fact, that this may be the case, and we're quickly exploring that in ongoing clinical trials right now. And I think this actually very much may be the wave of the future in years to come in uveal melanoma. So let me jump right in on the next slide and try to paint the picture for you of really what the haystack looks like in which the needles have recently been found. This is focusing in on the uveal melanoma tumor cells themselves. One can see, if you do a comparison between cutaneous melanoma and uveal melanoma, and specifically look at the chromosomes. So this is the entire set of chromosomes, a subset of which are known to have alterations commonly in melanoma. We have 23 pairs of chromosomes in each cell in our body. And as you'll see here, there's some numbers missing because not all of those chromosomes have alterations or changes in the setting of melanoma. But those that do are represented here, and you can see the comparison again across the different types. And there's a couple of standouts. Dr. Weber already alluded to the fact that chromosome 3, near the top of the list, commonly has alterations in uveal melanoma, but much less so in cutaneous melanoma. And being aware of this type of comparative data, which has actually been available for a good number of years, although published only in this format very recently, led us to believe that there might be distinct differences in terms of the genetic makeup of these tumors. So on the next slide is really just a very brief depiction of what's been uncovered just within the past 3 years now. And that is that there are basically 2 mutational events that appear to be absolutely critical occurring within the uveal melanoma cell in its initial formation, and then also relating to its ability to metastasize or spread. And the first of these two is the so-called GNAQ or GNA11 mutations. So those are 2 different genes that encode 2 different proteins, but they're highly related proteins. And one or the other, as I'll come back to in just a moment, is very, very commonly mutated in a way that turns on those signaling molecules inside of cells. And I'll give you a depiction of how we think these proteins work in just a moment, but bear with me. We think that the critical next step after these GNAQ or GNA11 mutations contribute to the proliferation or growth of a melanocytic lesion in the back of the eye, that after that further genetic changes are required. And specifically this protein that Dr. Weber alluded to, BAP1, or BAP1 as we call it for short, is very commonly mutated in a way that actually inactivates this molecule. And that turns out to be a critical step or gateway in terms of uveal melanoma picking up the ability to metastasize or spread. It's a fairly profound association that's been made between the link between this mutation and alterations on the chromosome 3, in which this gene is contained, that seem to be this critical gateway to metastatic potential. Now, one might argue then, well, then all of our focus should be on figuring out how to create drug strategies that compensate for this loss of BAP1 function or BAP1 function. And we do, in fact, have a lot of enthusiasm for that approach. But we have every reason to believe that we should equally be paying attention to the earlier step, the GNAQ, GNA11 mutations. And I'll explain during the course of my comments why we hold that view in the field. So on the next slide, I'm giving you a relatively simplistic representation of where these mutations occur in terms of how they affect cellular function. So I'm depicting for you here the surface, if you will, and the immediate interior components of a uveal melanoma cell. And the proteins GNAQ and GNA11 are part of a complex of proteins that are positioned at the membrane or the outer portion of these cells. Normally, these proteins are tasked with passing signals from the outside of the cell inside. So when the cell senses a change in its environment, it's molecules like this that basically pass that message inside the cell. And when there are mutations in GNAQ or GNA11, what that does is it causes these signals to be constantly sent in a way that makes the cell believe that it is under different conditions than it might otherwise be. And as it turns out, these are conditions that favor growth or proliferation of these cells. And it's been very clearly linked that these GNAQ, GNA11 mutations cause that type of change in and of themselves. BAP1 mutations affect a protein that has its critical function in the nucleus of the cell where the DNA resides. And that's what I'm depicting here on the bottom of this figure. The BAP1 is a protein that interacts with other proteins that then regulate the chromosomes, making them more or less available to be copied or expressed in a way that then contributes to abnormal cellular behavior, separate from the GNAQ, GNA11 mutations. The fascinating discovery made just a few years ago now is that about 80 to 90% of all uveal melanoma cases have a mutation in either GNAQ or GNA11, and separately, 80 to 90% of all uveal melanoma cases have a mutation that affects BAP1. So the overlap between these two, as you can imagine then, is very, very common, that you'll find a uveal melanoma that has both of these mutations present. And in fact, we believe that it's at least this higher percentage in uveal melanomas that leave the eye and metastasize to the liver, for example, or elsewhere. Another key point before leaving this slide is that we've come to understand rather rapidly how it is that cells are wired internally. So we would like, ideally, someday to be able to directly develop drugs that block the function of GNAQ or GNA11 when a mutation is present. That would be our ideal scenario. But until such time as we are able to do that, we would accept the strategy of blocking the molecules that are activated by it. So specifically, you see this molecule PKC, or protein kinase C, that is essentially directly activated by mutated GNAQ and GNA11. And this is the reason why there is an ongoing clinical trial as we speak, specifically focused on patients with metastatic uveal melanoma using an inhibitor of this molecule, PKC. And that study is ongoing, and we await the results in the near future. PKC then activates other pathways, as we call them, which are essentially bucket brigades of molecules that activate one another. And this chain of activation then ultimately alters the nucleus in a way that changes the cell behavior, in this case contributing to cell growth, we think, as the predominant feature. And we currently are aware of drugs that are capable of blocking some of the components of these pathways. So we're working...
Keith?
Yeah?
Oh, sorry, it's Sarah. We lost you for a little bit there.
Oh, sorry. I'm on a landline. I would have hoped that would keep me connected.
Let's,
Do you want to go back to, I think, the bucket brigade is where I lost you.
Yeah, sure. Yep, okay.
So again, the notion here is that these molecules near the cell surface communicate to other molecules that then pass the signals further into the cell and ultimately affect the nucleus and how cells behave in a fundamental way, with these pathways shown being ones that are critical for the growth or proliferation of tumor cells. Probably also some significant effect in terms of promoting survival of these cells, even in the face of potentially tough conditions for these cells to survive. And so the ideal scenario would be that we successfully develop drugs that block GNAQ or GNA11, and there's extensive scientific work ongoing right now to try to do that. Absent that, we would accept a strategy of blocking downstream, as we call it. So, for example, PKC or protein kinase C, for which there's an ongoing clinical trial. And then, absent success there, we'd be willing to look at a strategy, and in fact are looking at strategies, to combine inhibitors that block some of these downstream pathways. For example, there's recent scientific evidence that blocking the molecule MEK with one of the elements of the PI3K pathway might be an alternative and successful strategy. These types of strategies can be evaluated fairly effectively in the laboratory, even with isolated uveal melanoma cells that have been taken from biopsy specimens or surgical removals of uveal melanoma in years past. And that ability is something that is actually quite distinct from immune therapy, which, as Dr. Weber can tell you, is very difficult to evaluate in laboratory models because we simply don't have model systems that reflect the full complexity of a human with an intact immune system and a tumor in place and so on. But the strategies I'm describing actually can oftentimes be nominated as being potentially effective based simply on laboratory evidence with potential new drug approaches. Another very, very promising avenue would be if we can develop drugs that accommodate or counter the effect of BAP1 mutations. These are mutations that inactivate BAP1, so being able to restore it may be a real challenge, but understanding how it triggers altered signaling inside of the nucleus of cells, we believe will present us with opportunities to do that, and I'm going to highlight that in just a moment. Next slide, please. So I'm just trying to show you this beautiful cartoon to make the point that while we understand in exquisite detail the structure of these GNAQ, GNA11 proteins, which have a nearly identical structure, and we know precisely where the mutations occur in this molecule, best depicted in the lower right-hand corner of this diagram, that's not the challenge, understanding the makeup or structure of this protein. The challenge is that when these mutations occur, they actually disable the ability of this molecule to turn itself off. So they ultimately then are disabling mutations that result in this molecule being stuck in the on position. And technically, it is quite challenging in the scientific field to create drugs that will force this molecule or molecule like it into the off position. Yet that is what's being sought currently in ongoing research. Just to be clear, though, it is quite a difficult challenge in comparison to some of the other targeted therapy successes that have been realized in melanoma and elsewhere. Next slide. And the story is a bit more complicated, perhaps, than I've alluded to already, in the sense that these networks of signaling molecules, or bucket brigades, in fact, are interwoven in a way that makes it so that GNAQ, GNA11, which in this cartoon are depicted here in the top middle portion, can go multiple different directions at once, and perhaps affect other pathways that I didn't allude to on the previous slide that we may need to take into account. And so this is where it is absolutely critical that we exert ourselves in terms of laboratory studies right now to understand literally how these cells are wired, because it may well be that it's a drug approach that we haven't yet thought of that would be the optimal strategy for intercepting what GNAQ and GNA11 are trying to accomplish. Again, we will continue to be very focused on one hand on trying to develop direct blockers of these mutations, but until such time as we're able to do that, we would certainly like to develop strategies that may be more tractable in the near term. Next slide. Now, BAP1 or BAP1 is a totally different type of molecule, and here I'm just demonstrating that over the whole structure of the gene and protein BAP1, which is the blue line with the boxes distributed on it, that one can find mutations in uveal melanoma in several domains of this protein. In other words, the mutations don't occur in just one place. They do tend to cluster, but they're not associated with only one domain of this protein. And that likely means that there are different consequences that can occur with different BAP1 mutations. And we're just starting to sort this out in laboratory studies currently. Next slide. When you look at BAP1 in a different way, here's a depiction of the protein in its fully folded form. You see where the four most common mutations occur. And they affect a part of the molecule, or an interface of this molecule, that we know interacts with other proteins that are then a critical adapter or modulator of how the DNA folds and unfolds, how the DNA is essentially silenced or woken up to be copied or to have certain genes expressed. And so this, we think, is probably a mutation event that has fairly far-reaching consequences, and trying to figure out how to understand the interface between this protein and other proteins is likely going to point us towards where to target drugs, because this depiction right here would actually be very challenging to try to create a single drug that could cover where all of these mutations occur. We would likely have to target each of these domains in a distinct way. So this is probably going to be a strategy where we're going to have to personalize targeted therapy strategies to the type of BAP1 mutation that we find in an individual person's melanoma. Next slide. But there is some early evidence, in fact, that we may, in fact, have drugs in hand that can help to sort of counter or ameliorate what it is that altered BAP1 function creates in terms of the genetic alterations that lead to abnormal cell behavior. What I'm showing you here is just the result of a fairly simple experiment where uveal melanoma cells were grown in the laboratory, in a test tube, if you will. And in the untreated condition, which is the left-hand block, you'll find that these cells will multiply, much like the uveal melanoma cells will in the body. However, when you use any one of the three drugs that are shown on the right-hand side, you can block that proliferation, in fact, quite profoundly. And it turns out these are drugs that are currently in clinical trials for various types of cancers, in fact, have shown promise in several cancer types. And prior to the genetic discoveries made just within the past couple of years, would not have been thought to be relevant for uveal melanoma. So it is this discovery of these specific mutations that now is allowing us to hone in a good bit more in terms of drug strategies that might be useful, leveraging this genetic understanding. Now, these drugs do, in fact, have fairly far-reaching consequences beyond just interfering with BAP1 function. And so while this is very nice evidence that this approach might bear fruit as we execute clinical trials with this type of approach, it's possible that these drugs have consequences that are too far-reaching, in other words, cause side effects that are unacceptable on the way towards trying to cause this effect, as shown here in terms of blocking the growth or proliferation of uveal melanoma cells. And simply put, this is why we need to do clinical trials to evaluate this concept. So in this instance, the drugs, in fact, may be not too far away. And if this set of drugs turns out to have unintended consequences in terms of side effects that limit their applicability or usefulness, well, then simply put, we need to develop next-generation drugs that have a more targeted or focused effect on the altered function that happens as a consequence of BAP1 mutations. Next slide. But the reason that we're so focused on this approach is because we have seen success already with targeted therapy, and in fact in several cancer types. But here I'm showing you an example in cutaneous melanoma. Many of you are likely aware of the fact that in cutaneous melanoma, roughly half of our patients have BRAF mutations. BRAF is a molecule that sits in one of the bucket brigades that I was referring to in a previous slide. We don't find these mutations in uveal melanoma, but the point being that cutaneous melanoma historically was just as difficult to treat, just as refractory to standard chemotherapy drugs as uveal melanoma, and yet a single drug approach targeting BRAF in a very selective fashion has a profound effect, shown here with several examples of patients whose PET scans were showing the distribution of their metastatic melanoma on the left-hand side in each case, and on the right-hand side, after just 2 weeks of treatment with pill-based therapy, you could see these tumors virtually disappear on this type of imaging method, so-called PET scan. And next slide. And by measuring the tumors, in other words, measuring the shrinkage of tumors, we found with this type of approach, on the top figure, single-agent BRAF inhibitor therapy reliably causing tumor shrinkage, roughly 90% of patients having some degree of effect, including some patients with a single drug approach having complete disappearance of their metastatic tumors, at least for a time. And we've learned subsequently that a combination approach, two-drug approach, trying to take advantage of the presence of these BRAF mutations can lead to an even bigger effect, nearly all patients having some degree of tumor regression, and even more patients having these complete responses, as we call them. So we have reason to believe that these genetic discoveries that have really fallen into our lap because of the outstanding science that's been explored now in the uveal melanoma field for the very first time is going to give us the combination to the lock, if you will. And while uveal melanoma admittedly has lagged behind not only cutaneous melanoma but other cancer types in terms of having an effective systemic therapy strategy, we like to think that we are very much on the brink of discoveries that will lead us to this type of reliable effect that we've observed in cutaneous melanoma. And with that, I'd like to stop because we're hoping to leave some time for questions.
Thank you very much, Dr. Flaherty and Dr. Weber. We just went over a lot of information. I think I'm struck with really the amount of hope on the horizon that you've left us with. But you've also left us with, I'm sure, a lot of questions. So why don't we spend the next 10 or 15 minutes taking some questions, and then whatever questions aren't able to be answered, we can follow up with on the CureOM patient forum online afterwards. So why don't we go ahead and take some questions.
Sarah, can you see the questions that have been emailed?
No.
Okay. If anyone would like to answer a question or ask a question, could you please indicate by raising your hand on your attendee, and we will open up the mic for you to speak. I've got one from Stan Corin. Go ahead, Stan, your phone is open.
Okay, thank you very much. It's very informative. I'm here in Sudbury, Canada, and my father just passed away from OM. And, you know, I guess just trying to go over and over in my head what was going on. And when his eye was removed, it was just a matter of like, okay, thank God it's done. And now if the liver part happens, well, we'll deal with that down the road. And I just wonder, you know, these mutations, very interesting that you mentioned mutations of, and I wonder what causes these mutations. I guess that's my main question. And I suppose because, you know, now I understand from your presentation that it is so rare that I guess, you know, it's probably not worth it. But is there any ideas in terms of prevention or, you know, in the first place? I guess that's my question.
Yeah, it's a great couple of questions there. I'll tell you, we're in an early stage since the discovery of these mutations in the first place, just a few years ago, to understand in a deep way exactly how they happen. You can imagine, of course, the usual suspect is that we blame ultraviolet light, which admittedly does not get to the back of the eye nearly so readily as it does, let's say, to the skin, for example. And so, you know, one could imagine that there could well be instances where, you know, just the right amount of ultraviolet radiation could trigger one of these, sort of clicks in the lock, if you will, in the combination lock. You know, the first event, as it appears, being one of these GNAQ, GNA11 mutations, and then the second event being the BAP1 mutations. But we haven't proven that, and it is entirely possible that other types of exposures that have nothing to do with ultraviolet radiation could be partly responsible. And it's also possible that there are other elements that we simply haven't accounted for. Inflammation, other things that are going on either in the eye or elsewhere in the body that actually contribute to cells not recognizing these types of genetic alterations when they happen. Because, to be clear, when certain mutations happen in certain cells, it's common that those cells will actually die and never become cancerous. The mutations have to happen in the right conditions at the right time to be able to contribute. And we simply lack the insight to really understand that issue of causality. So I have to say it's a frustrating point for me, not only in terms of trying to help my patients make sense of, how these events transpired, but just as you're saying, perhaps the far more important point looking forward in generations to come is how do we prevent this? And we're just not there yet, unfortunately, in terms of having a deep enough understanding to know how we can do that or how to look out for susceptibility to this problem and susceptibility to these mutational events occurring.
Yeah, the other issue with respect to primary prevention of ocular melanoma is, well, there are two issues. One is being able to define a high-risk group, and that's not easy. Second is there's no way that the FDA would let you explore primary prevention until you had a drug or a vaccine or an immune approach that had some activity in later stage disease and had evidence that it was safe. Because anytime you treat someone to primarily prevent the cancer, the treatment will obviously be given to most people who are never going to get the cancer, and it has to thus be very safe because your threshold for accepting the drug is much, much higher safety-wise than it would be for a drug to treat metastatic cancer where everybody's going to die. So very different scenario, and that's going to take a long time to happen.
Thank you. Do we have another question?
Yes,
Scott?
we do. Just one moment. Leslie Kirkpatrick, I'm opening your line. Go ahead, Leslie.
Very much. Thanks for two good talks. I'd like to ask what you think should be done with people who have responded to ipilimumab. Should they go into maintenance therapy or just wait till they relapse again? And what are the chances of ipilimumab working a second time? I've seen graphs that at 2 years the survival curve becomes more like a horizontal line, and I just wondered what you're doing now, because those graphs would be a couple of years old now.
Well, the issues with ipi are two. Is a higher dose better than a lower dose? And I have a nasty suspicion that more is better. And that's been tested in a trial that filled up in like 3 months. It was like the fastest accruing trial you've ever seen. So the jury's out, but that will get an answer sometime in 2013. The next question is a really good one. Should you continue to treat people on so-called maintenance? And no one wants to do that trial. That's a trial I proposed years ago. And that's a huge issue. I'm not convinced that it's necessary. I predict that in some patients it will benefit them and in some it will not. And I admit that if you look at the patients who got maintained and those who just got 4 doses of so-called induction, there's not a lot of difference in survival, but wait till you see the data from 10. It may be a little different. Right now, to be honest, unless there's a trial with maintenance, I would get your 4 doses, stop, be closely watched, and if you relapse, there's a decent chance that you can re-respond to ipilimumab. So I would not rule out getting another go-round of ipi. Now, I do know from my own data that you can fail ipi and respond to PD-1. Now, that doesn't go for ocular melanoma patients. We haven't treated enough of them. As you know, they're rare, but my prediction is that they'll behave just the same.
We have a question that was submitted. Do you have information on, I hope I'm pronouncing this right, choroidal melanoma and veterans?
Choroidal melanoma in veterans, I do not. Actually, maybe Sara does, meaning implying people in the military have a higher incidence?
It was submitted by Mark Baynert. If Mark, maybe I can open the line for him just a moment.
Yeah, and when he said vets, I assume he meant veterans.
Mark, your line is open if you'd like to clarify your question.
Are you there, Mark? Well, maybe we should assume that the question is there a higher incidence of choroidal melanoma, which is the most common type of uveal melanoma in veterans? And I don't know any data that shows that there is a higher incidence in veterans.
I have never heard of it, and I guess one interesting question would be, and actually Keith probably knows this. Keith, is there a CT transition UV signature in the sequenced DNA from Bill Harbour?
Yeah,
I assume the answer is no.
Yeah, correct. The answer is no. I was alluding to that in my comment about we're not sure about a link between ultraviolet exposure and these mutations. There are, as Dr. Weber is alluding to, there are characteristic type of alterations that happen in the DNA code that we know are highly likely to occur as a direct consequence of UV exposure, and these changes that happen that create these GNAQ and GNA11 mutations don't fit that classic model. Doesn't mean that they're unrelated, but it just means that it's not fitting the mold at the moment. So at least that type of exposure that veterans might might have more sun exposure, it's not clear that would create a link. But there, of course, as I commented before, it's entirely possible there's other types of exposures that relate to uveal melanoma risk. And is it possible that veterans bear more of a burden there? I'm not aware of current evidence that makes that case yet, but I'm not sure it's been looked at carefully.
We probably have time for another 1 or 2 questions.
Okay, we have a question submitted by Keith Tanner from England. Many of us had tumors which were too thin to biopsy or were treated before biopsy became possible. Is it likely that at some time in the future we might benefit from these emerging treatments, or can these only benefit those who have had gene assessments?
Great question. Let me try to tackle it this way. You can imagine that if someone were to have a recurrence of uveal melanoma in the liver or elsewhere, we can and do biopsies at that time to assess the presence of these mutations, because it currently is guiding us in terms of our thinking for targeted therapy clinical trials. Now, absent that scenario, if what you're asking is, I had a uveal melanoma treated in the past, currently no evidence that it is present and now, and obviously hopefully that it never will be, would there be any utility in these types of therapies as a preventative measure, even without knowing the genetic makeup of that individual's uveal melanoma? There I would say that's, here I'm looking ahead a good number of years from where we are right now. If we're able to establish that this type of approach can be effective in controlling metastatic uveal melanoma, comparable to what we've seen with the BRAF approach in cutaneous melanoma, then one can absolutely anticipate that we will be using this approach in the clinical trial setting initially to see if it can help protect from recurrence, so-called adjuvant therapy. And because of how common these mutations are, 80 to 90% of uveal melanomas having these mutations that I referred to, it might be very reasonable in that era, which again is, we have years to go, unfortunately, before I think we'll be there. It might be totally reasonable to think about treating patients who we think are at significant risk based just on clinical features if genotyping is not available because the tumors are simply too small to think about that approach. But I think, again, we have a lot of hurdles to clear before that time, but I could envision the day where that would be the case.
All right, do we have time maybe for one last question?
Okay, another one that was submitted. I'm about to start proton radiation treatment. Do you suggest something in addition to that?
Well, I'll jump on that one. That sort of picks up with my previous comments, which is the idea of, is there a therapy beyond treatment of the eye, which we think is highly effective in terms of eradicating the tumor there? Is there a treatment that we could use to try to kill microscopic deposits of melanoma that are trying to travel elsewhere in the body, or that type of concept? That's what we refer to as so-called adjuvant systemic therapy or drug therapy. And we simply don't have any knowledge right now as to what that drug approach would be or should be. It's entirely possible that immunotherapy, as Dr. Weber summarized in his comments, could be that therapy. Or it's possible that targeted therapy could be that therapy, or an intersection of the two. We just don't yet have the evidence, and it's going to take us a little bit longer to generate it, unfortunately, to know. So the 2012 answer, and frankly the 2013 answer, will be treat the eye, and obviously have a discussion with your physician about whether there should or shouldn't be significant concern about this possibility of spreading elsewhere.
All right. Any last closing thoughts or comments, Dr. Weber, Dr. Flaherty?
I would think the last comments would be, I think that we certainly need to push sponsors to not exclude ocular melanoma patients from promising immunotherapies, although admittedly, given the rarity of the disease, once it spreads, in any randomized trial you're going to have to stratify for them, or to quickly move to a small separate trial of your new drug to include just the oculars.
Yeah, and I think that's a really important point, and something that the Melanoma Research Foundation and the CureOM initiative is definitely very interested in advocating for and being involved with that. So thank you for that comment. I want to thank you both so much for your time and your great explanations, and just for all that you do on behalf of ocular melanoma patients everywhere. I want to thank everyone for joining us today, and as questions come up, please join us on the CureOM online forum with additional questions, thoughts, concerns. We can always be in touch that way through email, on Facebook as well. We really want to be able to support you, the ocular melanoma community, as robustly as possible. So please be in touch with us. We look forward to seeing many of you in person at the meeting in Houston in March, and we'll continue with our webinars and scientific meetings and continue to really push both patient education, physician education, and the research forward. So thank you all very much, and we look forward to being in touch.
Great. Take care.
Bye-bye.
Bye.
Bye-bye.